So just to get started, I want to say, as social scientists committed to understanding the complexities of human societies, it's important to begin by acknowledging the land that which we gather. The University of Toronto operates on the traditional territory of many Indigenous nations, including the Huron-Wendat, the Seneca, and most recently the Mississauga of the Credit. The land has been a site of human activity, governance, knowledge exchange, and cultural expression for thousands of years. It remains home to many Indigenous people from across Turtle Island, and we recognize the enduring presence and resilience of First Nations, Inuit, and Métis communities. As we engage in scholarly inquiry, let us reflect on the responsibilities we carry as researchers, educators, and community members to respect Indigenous knowledge systems, histories, and rights.
Welcome everyone to the Reframing Pain Conference. I cannot tell you how thrilled I am to have this day finally arrive. At this particular historical moment, I think it's more important than ever for us to gather together in the work that we do toward equity, toward social justice, and be able to support each other. So PEPPR is the project from which CASPR emanates. So PEPPR has two main objectives. The first is to bring an equity lens into this notion of patient engagement in research and to really explore both what that does look like and what it could look like. And then the second objective, which relates directly to CASPR, is that we have a mission to advance critical social science approaches in the chronic pain and pain research spaces. We are inter and multidisciplinary. We have anthropology, we have sociology, we have nursing, philosophy, occupational therapy, physiotherapy, psychology, social work. You name it, the disciplines I think are represented through CASPR. So thank you so much everyone for being here, and thank you to all the speakers who've traveled so far to join us today.
We'll begin with a two-part shameless plug. The work and argument we're going to present here are in part from our recently published article from the Canadian Journal of Pain, The Intersectional Implications of a Quantitative Epistemology in Pain Care and Research. So if you're interested in that, it is open access, and it's open access thanks primarily to the funding we have from our grant. It's a SSHRC Insight Development Grant called Documenting the Epistemological Trajectory of Neurological Pain Research. So I know we have mostly researchers here, but if you are a practitioner or know practitioners, seems like some of you do, who are using or consider using brain-based technologies for pain measurement or treatment, we would like to possibly speak with you. So now that I've done away with the plugs, thank you. Let's move on to the meat of the matter, which will also hopefully explain why this grant is even relevant enough to mention. What we're going to talk about today is a result of our efforts to ground critical pain scholarship in material case studies, from the historical to the contemporary. That is, we've been working separately and together to think around the clinical tools used to measure various aspects of pain. Y'all are familiar with them: the visual analog scale, the face-based pain scale, the body map for pain, app-based technologies, and more recently, neuroprosthetic developments. And critically, we're considering their historical antecedents. Thank you. Because ultimately, the argument made in this paper that we've cited here by Schaffzin et al. From mid-2023, and their argument is basically that brain implants can help them identify quote-unquote objective biomarkers for pain. This argument is not new. Certainly, the whole process of drilling into someone's head, inserting electrodes connected to a device surgically implanted into their upper chest cavity that they can walk around with while it records thousands of data points, that it then compares to a massive corpus of similar data in order to make predictions on the severity and location of a patient's pain, maybe that part is new. But this effort to turn pain into something that need not be actively communicated in a complex and nuanced manner by the patient is well over 100 years old. And so in that sense, we're thinking here about two sorts of translation. One from the old to the new, and one from the qualitative and subjective to the quantified and objective. In other words, we're interested in both the incommensurate nature of pain evaluation and the commensurate nature of tools mediating pain measurement. So I'm going to pass it off to Michelle to define a few key terms.
Yeah, I'm going to do that thing that philosophers love to do, which is just talk about concepts and delineate between them. So commensuration, to begin, is a term that refers to the ability to measure, compare, or evaluate two things using a shared standard or language. Even if the two or more things are different, commensuration involves making them comparable, lining them up against a common criterion to evaluate them. An example of commensuration is ranking universities, for instance, and colleagues by faculty salary, for instance, or an assessment of a daycare quality via caretaker to child ratios. A related concept is quantification. So quantification is a form of commensuration. It's the process of turning something into a number. It's a tool for commensuration. So pain is often quantified in service of commensuration. So the visual analog scale is an example. It's a numeric scale that allows physicians to compare a patient's pain numerically from one appointment visit to the next, or even between two or more patients in research contexts, for instance. And we've already talked a little bit this morning about some of the challenges in doing that. We want to highlight that this is a normal compulsion that we have as human beings to classify, to quantify, but it can have consequences that have been implicitly sort of evaluated this morning, and we're going to do that as well. Okay, so incommensurability then, in the sense discussed above, would refer to when two entities are fundamentally incomparable. So going back to the daycare example, I think this is particularly poignant, right? The incommensurability of children at the daycare. You can imagine that two different children might not be the same. In the context of pain, person A lives with, they score their pain a 5 out of 10. They live in pain all alone, versus person B who scores their pain a 5 out of 10, but they have a network of support, so this is going to complicate this metric. I have an excerpt from Eula Biss here on her creative nonfiction called The Pain Scale, and she does a really excellent job, as do many other artists, of highlighting this incommensurability. So she's here comparing different types of pain. You can see that they're not necessarily comparable. But we also want to highlight how the term is used by STS scholars, so science and technology studies scholars, to describe the lack of compatibility between scientific paradigms. So now we're kind of zooming up. And so in this broader macro level sense, incommensurability refers to a situation where different scientific paradigms or ways of understanding and investigating the world are so different that they cannot be directly compared or evaluated by the same standards. So a paradigm, in Thomas Kuhn's sense, is a shared set of practices, standards, and examples that guide normal scientific work. It shapes how scientists define problems, interpret results, and what they consider legitimate science. When two paradigms compete, it's not just that scientists disagree about the answers, they actually often disagree about what questions even matter in the first place, how to judge answers, and even about what the world itself looks like. So the classic example is Newton. Before him, scientists thought forces needed causes. After Newton, gravity could simply be accepted as a natural fact, no cause necessary. This change meant that certain old questions stopped being asked altogether. And it can take a very long time, sometimes generations, for new paradigms to take hold, as with Copernican astronomy or Newtonian physics. So Kuhn believed that successive paradigms are often incommensurable, meaning they cannot be directly compared or fully understood. Following a number of STS scholars, Scott Graham, who was mentioned earlier, we reject the incommensurability thesis. We suggest that multiple paradigms for understanding pain employ similar frameworks of commensuration. And so in this sense, these paradigms coexist and are linked in a material discursive sense. And I think we've already kind of seen this today in some of the discussions, that some of these paradigms, like the biopsychosocial model, sort of just get tacked on to an old one, and they're sort of trying to kind of figure out how to mesh together, right, rather than a whole revolution. Okay.
So when it comes to the ways that pain has been measured and communicated over the past 100 years or so, what we'd like to argue here is that there really hasn't been that sort of Kuhnian paradigm shift. And I'll cover 3 paired case studies, each highlighting a theme present in the Schaffzin paper on the neuroprosthetics for objective biomarkers, as well as a historic antecedent. So I'll start with specificity theory, the idea introduced by Descartes that pain must be specifically locatable. If you can't find it, then it doesn't exist. And we've all seen this diagram, but the key here is that pain is measurable in terms of noxious stimuli and transmission pathways. Now, of course, when relying on electrodes or matrices of electrodes, it is paramount that locations be exact. And in fact, one independent physician not involved in the study opined to the Wall Street Journal and said, out of that beautiful symphony of rhythmic electrical activity patterns, we need to be honing in on that one player in the orchestra that has not tuned their instrument. This paper, the Schaffzin paper, really provides some fundamental insights of where in the orchestra to look and what specific notes aren't played properly. Next, we can look at the dolorimeter, a device popular in pre-war drug trials wherein a bit of ink would be placed on a subject's forehead and a beam of light would be shown at the spot. As the technician increased intensity, the study participants' ability to withstand the pain would diminish. The tech would then record the intensity, which forced the participant to react. Schaffzin et al. Were not able to confidently point to a correlation between certain brain signals and pain intensity, but we can't discount the effort made. How will thresholds of intensity be determined? Much like the so-called step of a Fitbit or an Apple Watch must be pre-programmed to represent a normative body's movement, against what data or metric will neuroprosthetic pain detection be calibrated? So we consider location and intensity, but what about the validity, the so-called validity of the pain report? What we know today as the body map for pain, as you can see here, can generally be traced back to a 1949 paper in the New Zealand Journal of Medicine by Dr. Harold Palmer. He argued that the way the patient filled out the form indicated whether it was, quote, an organic lesion or a functional nervous disorder that was causing the pain. And so you can see here that he says, when a patient complains of pain, we may infer either that his symptoms relate to an organic lesion of the tissues, and he basically says it's all based on whether or not he draws on his body map symmetrically or neatly, in which case it must be a functional nervous disorder. So the paper that I'm referencing on the right here is a rather nascent project. It's absolutely indicative of an effort to assert that expertise does not belong to the patient, right? So they're arguing this is great, we don't need the patient to be awake to tell us how much pain they're in, we'll just figure it out based on their brain signals. And it belongs to, in Palmer's case, the practitioner, or in the latter case, the AI. That's where the expertise is, which is really just to say those who wrote and used the software.
So again, although the drive to measure and quantify is human, commensuration of pain via common metric, particularly quantification, does not always succeed at making pain truly comparable. This is because there are numerous experiential paradoxes in first-hand accounts of pain that challenge the utility of these metrics. So I'm just going to give you 3 examples, and these come from Drew Leder's work, who's a phenomenologist who lives with pain. And so one of these experiential paradoxes he talks about is sensation and interpretation. So Leder's leg pain felt sharp when he thought it might be a stress fracture, heavy when associated with varicose veins, and burning with a neuropathy diagnosis. So basically the same pain changed in quality depending on its interpreted cause. Another paradox is the certainty and uncertainty paradox. And Eula Biss writes about this as well. So while Leder knew he was in pain, he was certain of his pain, he struggled to pinpoint its intensity on a scale of 0 to 10, or identify exactly where it was coming from. He might have a burning, but it would sort of radiate throughout his whole body. And then there's another third, the present and projective paradox, which was that pain kept pulling Leder into the unbearable present, so he couldn't think beyond it, yet it also forced him to project outward, eagerly awaiting appointments, hoping for diagnosis and relief. Furthermore, the lived experience of pain shows that cultural, environmental, and material factors greatly impact how we experience pain. This means that one person's 5 out of 10 might not be directly or at least meaningfully comparable to another's 5 out of 10. This critique can also be applied to commensuration that relies on non-numeric standards, such as the SP pain categories or metaphors for pain used in the McGill Pain Questionnaire. So Joanna Burke, who's a historian, writes of how Finnish speakers, for instance, do not understand the punitive category in the McGill Pain Questionnaire. They don't understand how that could be a kind of explanatory system for talking about why one is in pain. So those are some examples of incommensurability.
So in that CJP paper that I was bragging about at the beginning, Michelle and I use a few case studies of pain measurement techniques that, despite their logistical shortcomings, could be models for the future of the field. But we realize we're fighting an entrenched paradigm here, one reified by systemic limitations that we can't even begin to get into today. Spaces like this, however, are encouraging, and we hope to chat with all of you further throughout the day. So thank you very much.
Thank you. So the paper that I'm going to talk through today is based on a relatively recent area of my research, which is turning to fMRI imaging as part of this book on pain and visual images. And so I'm really interested in your feedback. It would be really helpful, anything that you've got. So firstly, I think it's important to recognize that imaging scans of bodily trauma such as X-ray and MRI, are widely recognized not to correlate very well with physical pain. And so, for instance, people may have MRIs of their spines and show quite a lot of damage but not be in pain, and vice versa. But imaging is a very key portion of contemporary biomedicine in terms of the diagnostic component. So there has been a very strong interest in developing objective biomarkers for pain. And usually this is framed in terms of an interest in finding measures for pain for people who can't communicate it very well, for children or for people with dementia, for instance. There may also be an interest in developing an objective pain scale, as Gabi and Michelle have been talking about, particularly in order to compare pain levels and particularly in order to show which treatments work best or don't work. But it goes beyond better pain communication, and here I rely on Scott Graham, who's been cited several times today, in his work on the empirical discursive ontology of pain, where he says the patient's report of pain is subjective and therefore inherently untrustworthy. And so the laboratory practices of contemporary medical science only recognize certain types of phenomena as real, and a patient complaint doesn't fall under that rubric. So there are constant attempts to try to make it, to discipline it in a sense, so that it falls under that rubric, so that we can get some objective evidence of pain. And normally that is through translation into a quantitative kind of measure. So what is it that we're seeing when we see those pictures that all of you will have seen of brains lit up with different colors? I'm going to go through briefly the way that fMRI scanning works. So the move to neuroimaging has been about trying to find objective evidence of pain in the brain. What we're seeing is fMRI using the fact that everything that the brain does is correlated with regional blood flow and changes in oxygen consumption, and that oxygenated and deoxygenated blood have different magnetic properties that can be picked up through magnetic resonance imaging. So the higher the ratio of oxygenated to deoxygenated blood in a particular area, the higher the energy consumption in that particular region. And then a subtraction technique, which is normally performed by specialist computer software designed for fMRI, is used to show the difference between the baseline scan and an active scan. For instance, if acute pain is induced, often using electrodes and heat, and what's left over is then highlighting the area of the brain that is involved in that particular activity. The colors that we see are a statistical representation of the data and show the likelihood that the findings of increased activity are due to chance, with brighter colors being ones that are more certain and darker colors being ones that are less certain. The software often maps that data onto a template of the human brain. And it's important to note that despite many years of development, this is not a method that is usable in clinical contexts at this point. So it is used specifically for research purposes. It's not used in the clinic in terms of proving people's pain at this point. So there have been a number of methodological challenges that have been put forward about fMRI over the years of its development. First one that I would point to is the experimental design question, and the fact that interpretation of these scans is not straightforward. So is a specific type of pain caused in an acute context, an acute experimental context, generalizable to other contexts? Can we say the same kinds of things about chronic pain that we can say about acute pain? Are those findings transferable? There are also issues about the software maps of the brain, which often are derived from a particular set of images of subjects who had a mean age of 25 and no psychological or neurological issues or medications. And as such, that's a population that's not very representative, certainly, of the people that we see with chronic pain. Much less, it's not even representative of populations as a whole, but particularly people with chronic pain. There's also an ordering problem around reverse inference, where researchers scan the brain, induce the condition of pain, and then scan again, and then say that what they've seen in the second scan is pain. But there has been debate about whether it's pain or simply something like salience. Is it the most important thing in the environment that your brain is paying attention to? So despite all of the search for a pain center in the brain, there's still quite a lot of debate about whether such a thing can or will exist. And finally, there have been statistical questions raised and criticisms as well about overly high correlation values, which may be caused by some questions around sample selection and also potentially high rates of false positives in clusters of the brain that are being shown because the statistical tests that are being used are violating the assumptions that are necessary for those tests to work. So there are a number of questions that have been raised here. But probably the biggest issue in this kind of pain research is its oversimplification. So the human experience of pain is being reduced to brain activity, and the treatment strategies that are derived from that or proposed from that are largely divorced from broader social context. For researchers in pain science, this holds promise because if a neurosignature for pain can be consistently identified, it can lead to treatment interventions that are measurable, and we can provide evidence that those treatments then work. But I'm very fond of this quote by Stilwell and Harmon, where they compare finding pain in the brain to being like saying that flight is in a bird's wings. We need a brain in order to have pain. We need wings in order for a bird to fly, but that's not enough. It's necessary but not sufficient. So we need to consider social and environmental context and the whole kind of ecosystem around those things and the environment that we shape and that shapes us. So I want to suggest that we won't find pain by trying to image it within the body or the brain, because pain is always relational. As Lucy Bending puts it, it's always because something. Whether those reasons are social in the ways that we talked about earlier and the complex interaction that has with our physicality and our biology. So I think that there are probably some things that neuroimaging can learn from critical social research, but I also want to finish by thinking about the reverse question as well. So these points I've drawn particularly from science and technology studies and some insights there. So firstly, in Steve Wogar's early work on software, and he describes how it configures the user and embeds a particular version of the brain. So that embedded model of the brain, when it's derived from an unrepresentative population, may not recognize diverse brains and brain activity in the same way. So there's a possibility that it might not recognize pain in minoritized populations in the same way. There's a risk that those images reiterate social injustices by configuring their users in particular ways. There's also a question around how neuroimaging works with phenomena that are not distinct and not easy to see. So Gabrielle Abend argues that when looking at things like love or morality, there's a lack of operationalization of what's going to be measured. So a question of how do we know what's pain versus what's not pain? How do we identify that particular thing? And that's not a given, and it's not a question that many researchers in neuroscience who are doing this kind of work are asking themselves necessarily. And Abend suggests that actually talking to more social sciences and humanities scholars would be useful in this regard. And finally, there is the fact that neuroimaging is borrowing much of its kind of legitimacy and scientific authority from other forms of imaging. So using things like digital photography or X-ray, we have this analogy that it works as if it's making pictures of our brains, but what we're actually seeing is a statistical map. It's not an image of an individual brain. And normally the images that we do see with those colors are put together. They're a kind of a model of several brains within a particular study. It's not that you're seeing one person's brain light up in that sense. So what could we learn from neuroimaging? And I fully accept that this implies that we don't want to reject everything about neuroimaging, that there are things that we might want to take from it. And I think here there are two things that I would suggest. First is that the theory of pain as a response to threat, or something that acts as a kind of a neural alarm system, could help us to explore how pain is entangled with social inequity and map those relationships in more depth in a way that acknowledges the real physical consequences of social injustices that I don't necessarily see always in my own discipline of sociology, for instance. And second, I think there are a number of studies that have emerged around the similarities and differences between social pain and physical pain. And what I have noticed in social and cultural theory around pain is that there's sometimes a tendency to elide the differences between those two things and to slip easily between talking about pain on a physical level and pain on a social level and political level. And I think more careful attention to those differences might help us to build a stronger sense of the kinds of claims that we make around pain.
Thanks, everybody. I want to preface this talk by saying that although I've been working in the chronic pain area for over a decade now, measurement has been kind of a specter that haunted in the background of all the work we're doing. It's not central to my program of research. And it's not so this is not kind of the culmination of my life's work so far, but I've been thinking a lot about how to deal with this specter of measurement that's been in the background of our work. Thinking, reading, reflecting, revisiting several studies that I've been involved with several people in the room. And I decided to use this talk as an opportunity to share an idea that I'm working with. And I think I had hoped that this would be kind of a welcoming environment to provide me with feedback on an idea that is germinating more so than kind of report on finished research. So with that in mind, the title of my talk is Everyday Indicators, ? Anthropological Insight into Better Metrics for Chronic Pain. So about 8 years ago, as a postdoc, I worked with Dr. Fiona Webster on an institutional ethnography that was looking at the social organization of chronic pain care in Ontario. And as part of this study, we interviewed medical trainees, specifically students and residents, about their experiences of and perceptions of learning to treat patients who had chronic pain. And our motivation for this initially stemmed from a large body of primarily quantitative research, which I'm sure many people in the room are familiar with, which shows a decline in empathy for chronic pain patients over the course of medical training. So we were very interested in looking at the experiences that underscored that decline in empathy. So a key finding of this study was that trainees, surprise, surprise, struggled with the private and subjective nature of pain. They explained that their inability to test for it or measure its intensity beyond using self-reported scales, 1 to 10, the type we've talked about a lot today, made care for these patients less straightforward than caring for patients with other chronic conditions. So statements like this were ubiquitous across the interviews. I think one of the hardest things about pain is that it's so subjective and we can't feel what our patients are feeling. We have scales where we measure pain, but we don't really have a way of knowing. Sometimes if the patient is like, I'm in pain, I need more medication, I'm like, they don't really need more pain medication. They're just being a suck or something like that. And then I feel bad saying that because how do I know what pain they're in? And we really don't know how to test for pain. I can't do a blood work level and know exactly how we should treat it. So
The care providers that we spoke with also struggled with their inability to cure chronic pain and reported that caring for patients who can't be cured, as many chronic pain patients can't, was less rewarding than caring for patients for whom care was more straightforward. And troublingly, we also found that trainees perceived chronic pain patients as having low educational value, and some of them felt that being assigned these patients was, quote, a form of punishment inflicted on them by their preceptors. So we don't have time today to go into the nuances of this research, but for those who are interested, you can read more here. For now, I want to hold on to the subjectivity piece and on the clinician's clear desire to measure and quantify pain as a means of overcoming the challenges that inaccessible subjective experience posed for them as care providers. So now I want to move forward to more recent research that I've been involved with, led by Dr. Fiona Webster and Dr. Laura Kanoy, the same study that Laura spoke about this morning, which focused on the work of living with chronic pain among people in Canada who are socioeconomically marginalized. Our analysis of this data showed that living with chronic pain is a deeply gendered experience where the work of living with, and managing one's pain is inseparable from the daily struggles associated with living with poverty, violence and trauma, gendered care work responsibilities, especially of children, and an overarching minimization of women's healthcare concerns. So much of this is captured in the following quote from Debbie. This is a cisgendered white woman with low socioeconomic status in her early 60s. And this is a short excerpt from a very long narrative about her struggles. So she said, I have had 2 children, one is deceased. She was born with microcephaly and epilepsy and CP and lived to be just short of her 15th birthday. I was sexually assaulted by a family member when I was about 8, 9, and 10 and suffered with depression since my early teens, more severe after my daughter was born. I've been on and off medication, been in counseling all along. They're thinking I have fibromyalgia. I have osteoarthritis in a number of parts of my body. I have bladder incontinence, irritable bowel syndrome, post-traumatic stress disorder and bulging discs, back problems, wrist problems, hip problems. My son is obsessive compulsive, obsessive defiant, and ADD. He also has a severe substance abuse problem. He has 2 children, one in Winnipeg that's 14 and a daughter here that is 5. The mother also has a drug problem, so a lot of responsibilities falls back on our shoulders, and I find it very tiring. So I've been sitting for a while now ruminating on how these pieces fit together, and in keeping with the theme of this panel on how careful theorizing on the incommensurability of pain might help us better grasp how to respond to people like Debbie, for whom chronic pain is at the same time one of many struggles and also kind of inextricably bound up with all of these struggles that she's navigating in her life. And I've also been thinking a lot about the power and dominance of metrics and measurement of pain, the specter of which has haunted a lot of our conversations with clinicians over the years. So I'm an anthropologist, and in working through this stuff, I decided to read up on the small body of anthropological literature on incommensurability. And that's when I had this little aha moment, which is what I want to walk you through now in the rest of this talk. To my knowledge, most of the anthropological literature on incommensurability does not actually come from medical anthropology, but rather legal anthropology, notably in the work of the late Sally Engle-Mary. In the years prior to her early death in 2020, Engle-Mary's research focused on human rights measurements and monitoring, drawing on years of multi-sited ethnographic research into the production of global indicators used to measure human rights violations. She offers rich and compelling insights into indicators as technologies of power, authority, and knowledge production. So this led her to describe what she terms the, quote, seductions of quantification, which are problematic in how they create false commensurability between the incommensurable phenomenon that they purport to describe. Honing in on the centrality of scales and measurement in this process, she notes that numbers are seductive because they, quote, offer forms of information that satisfy the unease and anxiety of living in a complex and ultimately unknowable world. They convey an aura of objective truth and scientific authority despite the extensive interpretive work that goes into their construction. After Engle-Mary's death, her critiques of the seductions of quantification and her insights into the incommensurability of meaningful notions of justice has been taken up by others, including fellow legal anthropologist Mark Goodale, who engages with the dilemma of how justice can be measured if the factors that supposedly reflect injustice are highly specific, contingent, and most importantly, incommensurable. Now, human rights and justice as problems for critical theory and practice obviously differ in very fundamental ways from that of chronic pain in healthcare context. But I think there are shades of similarity here, both in the primacy of quantitative and statistical metrics as a form of authoritative knowledge within a given domain, and in the kind of flattening of complex phenomena into tools designed to measure and quantify something that is complex, subjective, and highly context-specific. So in response, Goodale proposes a model of vernacular justice. And in his conceptualization of it's in this conceptualization of vernacular justice that I see some insight that I think might be helpful and relevant for how we approach the incommensurability of subjective experiences of pain. Goodale wholeheartedly agrees with Engelmary's critiques, but recognizes the importance of shared communication about a concept that is complex and contextual. Drawing on the theorizing of interdisciplinary development and conflict researchers, he borrows the term, quote, everyday indicators from conflict theorist Pamina Furchow, who describes them as deeply contextual, at least partly incommensurable, yet resonant. Everyday indicators are usually quite simple and deal with various aspects of our daily lives depending on the communities we live in. In Goodale's view, people in communities where human rights and injustice are pressing concerns, the people in the communities where human rights and injustice are pressing concerns should themselves generate indicators and categories to determine what constitutes injustice and what responses should be taken. As he puts it, he wants to make a meaningful effort to make the texture of social life the basis for evaluation, in which intervention and need are derived from the lives of non-elites rather than through the lens of cosmopolitan experts. So for me, what stands out here is a focus on functionality and grounding in lived circumstances as the criterion for developing tools and vocabulary to explain something incommensurable, and in some ways inaccessible to those outside of the subjective experience. To me, this holds promise for how to better approach the incommensurability of pain. And I'm not going to overstretch myself here and offer suggestions of what these everyday indicators might be, although I do have some ideas. And I certainly have some ideas for how we might go about soliciting ideas from people who know better than I do what those everyday indicators might be. But for now, suffice to say that a focus on everyday indicators of pain from the perspective of people with chronic pain shifts the focus away from needing to compare and quantify to gauge a reasonable reaction to a patient's pain, and also away from provider concerns about catastrophizing and fixations on possible psychosomatic dimensions of chronic pain experience. There's room here for the obligations and constraints faced by, for instance, women with pain who also have low socioeconomic status like Debbie. If cosmopolitan experts are swapped out for healthcare professionals, an approach focused on everyday indicators would recenter the patient, which I feel is an important place to start. Thank you.